Welcome to Everything Digital Health. My name is Marcus Bohr. I'm a GP and a clinical informatician. And today I'm joined by Jane Hayward, who I'll ask to introduce herself, if that's okay. Hi, Jane.
Hi. Thanks, Marcus, and thanks for having me on. So I'm Jane Hayward. I've been in the NHS now 39 years.
Wow.
I am a general manager and actually an accountant by background, but have been working in and around the IT space now for probably the last 20 years, being based on the South Coast in Southampton, and currently looking after a pathology network, an imaging network, and an endoscopy network. So almost everything diagnostics, and particularly working in the digital space.
Wow, that's a very cool portfolio of things that you've got there.
Mm.
And so today we decided that we're going to talk about digital diagnostics. So how about maybe we start with a general intro to that subject. What do we mean by digital diagnostics?
No, thank you for that. I mean, it's one of the reasons it's a cool portfolio, Marcus, is because at the moment, this is where the money is. And if you want to be successful in life, go where the money is in the NHS. So ever since the Richards report, diagnostics has been on the rise. It always feels like it's a bit of a forgotten cousin. You know, pathology and imaging and endoscopy, it gets a bit forgotten in the NHS. People talk about ED, they talk about elective waiting lists. But I think we saw both pre-COVID, but during COVID, that everybody in the country suddenly knew what pathology was. They knew what tests were, and they knew you could do them at home. So massive change in how people saw pathology. And suddenly pathology was everything in how you ran your hospital, how we were running society. What a change that was. So
yeah, I can imagine that would have been massive.
I know, absolutely massive. And the whole, whenever we talk now about point of care testing or wearables, but particularly point of care, you know, they trusted me as an individual and patients to self-test for the first time ever, and we relied on those results. So again, a massive shift in what society did and expects, and that's only going one direction. So the reason it's where the money is we've had 300 million to invest in digital diagnostics, and that's predominantly in what you'd think is the IT space, you know, the computer end of digitization. But actually some of that money has also gone into the machines. So in imaging, we've now got AI-enabled MRI machines, and that also came out of that digital diagnostics money. You know, normally in the NHS, we're really separate. This is for equipment, this is for IT. And for the first time, they combined it. So quite imaginative, I think. But that's given everybody an opportunity to think about what are the IT systems they need to go forward. And particularly linked about, you know, how can we be more interoperable? How can we do sharing? How can we be next generation? How can we change clinical workflows? So really exciting place to be at the moment, I think.
Yeah, I think we'll definitely come back to interoperability, because I think that's a very big area in here. Just whilst we're getting going, what sort of things are we talking about that at the very simplest level that might fall under digital diagnostics? So
the simplest level, if I talk about the things we're working on, and you know, for imaging, I always feel imaging in lots of places in the country quietly got on with sharing. You know, so we actually already had an imaging network set up. They already were sharing all their images, and what we've done is build on that. So we wanted to build on that. We've put more trust into the network and hoping to bring another ICB into the network. But actually, radiologists have been quietly doing this for quite a long time. Pathology was nowhere in this world for me. So in digital diagnostics for pathology, we have put in, or are putting in, a single limbs based on a single instance. We picked clinicists from the market, and we're halfway through that implementation, which means, again, we've got that sharing across trusts, across 7 partner trusts in my bit of the world, that allows more interoperability. It allows clinicians from across the trust to see what's happening, but also starts to allow us to work differently. So once you've got those basics in and you can start to share reports or you can start to share workflows, that's in a way, for me, the most exciting part. So in imaging,
let's just break down, what do you mean by, because there's a very wide range of audiences to something like this. What do we mean by a network? Because there's lots of meanings to that word.
Apologies. Yeah,
so
no,
what
absolutely.
Do you mean? You're talking about a very specific kind of network. It's not the digital health networks, and neither is it an Ethernet or wireless network.
No, sorry, apologies actually, because part of the Richards report said that actually what they wanted to see was people working together in clinical networks. So for us in Wessex, and Wessex is everyone in Hampshire and Isle of Wight, everyone in Dorset, and some of the people in Bath, Swindon and Wiltshire have been asked to work together across a number of things, actually: clinical pathways, delivering services differently, digital pathways, etc. So those networks have been set up and funded nationally to bring 7 trusts together. I think now partnering is everything, isn't it? The whole NHS is about partnering and acute collaboratives and working together. Some of those networks were before that. Some of those networks is when we were in full competition. Nothing must be shared with anybody else at any point. So they were a way of bringing partners together to work differently, I think.
Okay, thanks for that. It's an interesting thing that you mentioned competition, because that's something that I think the wider population imagines, that the NHS as a whole just generally works for the best interests of the patients, and that there's no perverse incentives in there. But you've raised an important point, which is that in theory, at least, the generation of a sort of internal market, which happened sort of in the last 15 to 20 years in the NHS, has resulted in the idea of trusts being in competition with each other in some kind of commercial sense, which it never really made any sense for the NHS. You get the feeling that we're coming to the close of that with the idea we're moving away from the Lansley reforms and those kind of things that cemented the idea of an internal market and competition. But we've still got foundation trusts, and they are essentially a business. That the foundation bit allows them to behave a little bit more like a normal corporation, as it were. So
I think we have definitely moved away from it, and arguably COVID sped that up as well. Really sped up the working in partnership. But the latest set of changes, I'm not sure we're not going back in the other direction again, and competition seems to be coming back in. When I worked in a trust, and at one point I had Director of Partnerships as my title, as one of my many titles, I think. And I used to ask everyone, when we talked about our values, when we talked about our objectives, was partnering one of the things we asked everyone to do? And it wasn't. And I still feel now, when I'm working with people in the 7 trusts I work with, they'll tell me, if things get tricky, they'll go back to, well, my manager doesn't want me to do that. My manager says our trust has to come first.
Yeah, it's a very bizarre standpoint, and it's one that the general population wouldn't understand as to why that exists, because it's counterproductive to their eyes, and I think it is counterproductive in reality as well. It might suit the internal organization of the NHS, and in particular the flows of money. I think it makes the job of apportioning cash easier if you can say, well, you're all in competition with each other, you get a certain amount of money, whoever can deliver the service at the highest quality for the lowest price is going to win. But these things actually don't really pan out in reality, and even what we imagine as the rules of economics and the market, even in the real market, they don't work. They're provably false. A lot of economics is founded on entirely fictitious assumptions about the reasonable person and what they will do in an economic situation. So it's not surprising it doesn't work in the NHS either.
No,
My own view is, as you'll know from me, is because of my open source background, is that partnerships and sharing and is everything. The NHS could be doing an awful lot more of that, and sharing its code, sharing its platforms, without charging each other as though we're in competition.
I mean, we are a really big beast, aren't we? That's the thing. You know, we're talking about organisations with, you know, billion pound turnovers, you know, with tens of thousands of staff, you know, and it makes that partnership, I think, very difficult. And I think, you know, if I had my time again with the networks, I would have started with leadership and development. I would have taken everyone away and put them in a hotel for 3 days, and we would have talked about understanding ourselves and understanding each other and how do we work together as a team. And as usual in the NHS, that wasn't funded, that bit. And instead we decided to throw everyone together and say, I know you've been in competition for 20 years, but could you all be friends now? And building that trust will take a long time.
Yeah, it's difficult to change that culture once you've already set it in place. And as you say, as soon as things get difficult, which they are at the moment, what with the abolition of NHS England and contraction of the ICBs, people retreat into their own organisation and they say, well, our organisation comes first and sharing comes second.
And I think the culture has changed, that pre-COVID, my watershed, massive benefits of teams and working together online, really huge benefits. But we all used to go and meet in a room, and half the conversations were formal conversations and half the conversations were informal conversations in a room. And I find now on Teams that almost every meeting is being recorded, and it really restricts discussion.
That's an interesting observation. Yeah, I think that it will have a chilling effect because everything now, anything that's recorded becomes FOIable. And even if you were having an informal conversation that results in benefit for the NHS, for the taxpayer, and for everybody who's a patient of the NHS, it still feels like you're doing something naughty if it's being recorded and potentially could backfire on you. And that's in an environment where I don't actually think people are generally engaging in anything that's illegal, immoral, or unethical around the NHS in these circles. I think at this level, people generally are having informal conversations about collaboration. That's very different to some of the areas where in much more senior parts of government, where I think there perhaps is a lot more going on that would be viewed as corruption if it was to see the light of day.
I mean, I would agree with that. And I think there's a behaviour thing there. And, one of the things I'm sure we'll talk about is AI. AI comes up all the way through digital diagnostics. But there is a big push now, isn't there, to say that actually AI can now really helpfully interpret the conversation between the clinician and the patient, record and summarize that. Well, if I'm nervous as a professional when there's a record button and I can see that, then maybe I'm going to be nervous as a patient if AI is recording what I've said. Interesting.
I think for those things to work, we need some absolutely cast iron guarantees that we can give patients as clinicians about who is going to have access to this data, how long it will be kept for, whether it will be used for training AIs on, and that sort of thing. So at the moment, we have no real data. And even if you did work in a trust where they perhaps have installed some kind of ambient listening transcription device, do you as a clinician get given the absolute cast iron guarantee that what you're saying to the patient is true? Are you even told what to say? Because I can imagine, having worked in lots and lots of pressurized clinical environments, that with the best will in the world, clinicians probably are undertrained because there's no time to train them on what exactly they should be saying to patients about the nature of this AI device. Because as you say, I think it's absolutely got the potential to revolutionize our transcribing and recording of a clinical encounter. But if the data from that encounter is going to be used to train a private company's AI to make it better, then essentially we are subsidizing that private company with NHS data. But we won't be being paid for it, because the NHS is traditionally almost comically incompetent at negotiating with private companies.
Yeah.
It's almost as if they're so excited to be talking to Google or Meta or OpenAI that they get starstruck and accept anything that is on the table without thinking, why do these companies want access to the largest single repository of data about patients in the world? Ask yourself.
Well, I think we understand that, but we've tried many versions now of getting the best minds into senior leadership positions in the NHS as a whole, haven't we? Best digital minds. And some of that comes down to how much we pay. It's as simple as that, isn't it? It is people's terms and conditions, and they will outbid us on every single occasion. So then you've got to do that whole bit about values and money to get the best minds and give them the freedom to act.
That's a key thing, that last thing. So actually, in the commercial sector, yes, you're very well resourced and you're very well remunerated, but you are subject to one absolutely cast iron restriction, which is the wishes of the company are what you will do, and there's no going around it. I think we could attract better people into senior digital roles in the NHS if we combined good enough remuneration with good conditions of work, and importantly, the freedom and the resources to actually make something better. Because a lot of people really derive a lot of meaning in their lives from being able to do something that genuinely makes things better in the world. And it's not purely about the money. When you're working, however, in an organization that's totally hamstrung, like a lot of NHS organizations, where we've got lots and lots of people in fairly senior mid-upper management roles, but no resources for them to do anything, they're just frustrated. And so it's not surprising that a lot of them will exit the door and go straight into the private sector, where it feels a little bit less frustrating, or at least you get paid more to be frustrated.
I mean, we're very off topic, Marcus, but I saw that. So one of the things when I was working in a trust is I had some responsibility for the IT department, and agenda for change just didn't work for any of those people. Agenda for change is really hierarchical. How many people do you manage? Are you a manager? There were some of the people in that department, I didn't want them to manage anybody. That wasn't their job. They were knowledge workers. They brought huge skills. And actually, I just wanted them to work on their own and manage a network. And I wanted to reward them appropriately. But Agenda for Change really doesn't understand that very well. And
absolutely. I've heard that criticism many times, that it has a very one-dimensional assumptions about seniority and about the value you can bring, and you can't get above a certain level unless you start managing other people. And that really, all that does is facilitate, it creates an incentive to develop more managerial roles, managing other managerial roles, managing other managerial roles, like a big kind of souffle of management. And yet there is nobody in there who can say, write software, because that is considered to be sort of blue collar work by Agenda for Change.
And that's just completely wrong. And I think the private sector understand that, and we still don't. So lots of things have to change to make us successful. And having said that, I work with brilliant people. Some of whom have come up the clinical route with an interest in IT and have topped up. Some people have come up the IT route and are now working in health because it's so interesting. People come from either direction, don't they? But and they are threaded through our imaging and our pathology teams as well as everybody else. So it's been really nice to work with them and see the things that they can see that are wrong and want to put right, and that's partly what we're trying to do, isn't it?
Yeah, I mean that's really cool to see, isn't it? I think we are a bit off topic, but I don't mind this kind of digression because it's important stuff. I think we have got a very large organization in which almost nobody talks publicly about these kind of things for fear of either organizational retribution, or they just don't have a platform to talk about it. And so one of the nice things about having this channel is that we can talk and get a little bit of that stuff surfaced. I mean, what you've articulated there is essentially we have an agenda for change pay structure that penalizes certain skills, and it means one of the key things is that we can't pay software developers and AI specialists enough to keep them in the NHS. And that explains entirely why we're so dependent on the private sector for all of that stuff. And yet we're not depending on the private sector for, say, consultants, because they're not part of Agenda for Change. They have their own pay structure, and that remunerates them enough to keep them in the NHS for now.
Absolutely. I mean, it's really critically important we have good people, and the less good people we have, the more we do rely on, for me, actually a shrinking number of companies in the, where I'm currently working across pathology and imaging. We imagine there's a fair market competition and clearly everything is tendered, but you can start to see across the country that certain companies are now emerging as market leaders and have got a huge percentage of market share. Interestingly, if we told everyone, if we'd done a national program that said, right, we're just going to go out and all buy the same thing, everyone would have gone, well, over my dead body will I do that. But instead, actually, they gave us all the money, and most of us have gone out and bought the same thing. And that's been a really interesting journey.
You would like to hope that if they're all buying the same thing, it's for a good reason. It probably is the better of the options that's out there.
Yeah.
That's what I would hope, putting my faith in the people who are making those decisions. There are examples of where we're working in a sort of anti-competitive way at national level. I think the federated data platform is a bit of a problem like that, because we've spent 15 years trying to create a little marketplace and an ecosystem of SMEs. And then in the last 5 years, we've essentially destroyed that by saying we're going to procure a single national federated data platform, and a lot of the data flows will come from that. So if you did happen to be producing, I don't know, a discharge summary product as a small, medium enterprise in the NHS, we're sorry, but you're going out of business, because in the future, all discharge summaries will come through the FDP. That's anti-competitive. And I actually think that some of the SMEs would have a reasonable case with competition law that they have been undermined in the marketplace, especially if they're not allowed to have access to the data platform itself, because they could be in the business of building apps for the data platform.
Yes.
And that might work. But if they're excluded from that data platform, then I think they should certainly look at their options in terms of challenging that legally. But anti-competitive behavior is kind of a hallmark of late-stage capitalism, I suppose.
I mean, we've got a good example, I think, at the moment of we're working on a national imaging registry, and the National Imaging Registry. So this is a national program. NHS IT are leading this. We're involved as one of the alphas, with a vision that says, although we can do image and report sharing mostly in networks now, actually, why can't we do that across the country? This is patient expectation, isn't it, Marcus? Well, if you walk into a hospital, you're expecting that hospital to be able to see the image you had yesterday and the image you had last year, and to know what's wrong with you. We know that doesn't happen. We can do it, but it's a bit clunky. So the National Imaging Registry is saying, well, actually, how are we going to share images and reports across the country? And their blocker, they imagined, was going to be the companies. Actually, the companies have been brilliant. The companies are really engaged. They want to use standards. They want to be able to share images, share reports, and the companies have really engaged with the program, which has been really good. Our blockers are going to come from other things. Our blockers, I always love it when we talk about standards, because standards in IT terms means, are we using FHIR? Are we using HL7? Well, we're doing all those things. We're using DICOM. Turns out we're not all describing an image in the same way at a basic level. So our first stumbling block is, well, NHS number, because we weren't using it, and we're not using it consistently across the country. So who the patient is and what you did to the patient is the big stumbling block. And even within our little area now, we're not describing a CT in one hospital is the same as a CT in the next hospital through a coded standardized system.
Wow.
And this is, yet again, I see this repeated through every piece of work I do, that although there's a national standard, we're not going to use it here. We're just going to do our own thing.
Yeah, that is what I think back in the dark days of NPFIT, National Project for IT, that they called to combat that not invented here scenario, they were going to try and use, I think the watchword was relentless standardization, ruthless standardization, that was the one, and force people to use standards. But in fact, what they ended up doing was really forcing people to use the same systems, which is different. So using the same computer system is a monopoly. Using the same standards is the opposite of a monopoly. That allows all of the systems to interoperate. So it's very interesting to hear you say that. So we've got what I imagine about digital diagnostics happening in a network area is that you've presumably got a vendor neutral archive. Is that what you do have, or have I got is that something from yesteryear that didn't quite survive?
I mean, for us, for imaging, we have a vendor neutral archive, but we have a vendor neutral archive with the same company that we've got our PACS system with. So we used to have different companies, and actually that didn't work for us particularly well. We have theoretically got a vendor neutral archive, but our archive is so big that you can't pick it up and move it anywhere. Last time we moved it took more than 2 years, and it was a lot smaller then.
Wow, how big is it? Just so I got a sense of scale.
Don't know, Marcus. Sorry, I don't know. That's my one stat, is it took 2 years. But these are images, and they're really big. And digital pathology, so the other thing we're doing is digital histopathology. Those images are enormous, the digital histopathology images. So at the moment, we've got all of those on premises. We're looking at a cloud solution for this. We're costing up at the moment, but it's much bigger than imaging. So we have a vendor neutral, but in theory rather than in practice, I think.
So it's, unless you've got more than one vendor with a client looking at your vendor neutral archive, you can't really guarantee that it is genuinely vendor neutral. No. Yeah, I see what you mean. So we're talking about very, very large volumes of data, images in general. And is DICOM still the kind of dominant format for things like CT scans and X-rays and things?
So DICOM works well for us, and within 5 of our 7 trusts, they're all in our sector platform, so they can be seen anywhere they look. You wouldn't know that the image had been taken in another trust. It just presents to the clinician if it's been taken locally. We're doing work with Dorset. Dorset have 2 different PACS systems and a different RIS system again, just through history. But we're doing a piece of work with them about sharing. So we're working on all our sharing protocols. We've done our first pass of test images, etc., through our sharing. And actually, again, the technology isn't the hard bit. DICOM's worked, the sharing's worked, through our XCI gateways, that's all worked. The problem has been NHS numbering and what the image is called. So actually it was back to the basics. And so we're working on NHS numbering. We've got a fix for that, hopefully, and then just starting to fix the others. But it's the normal peeling the onion stuff, isn't it? You don't know what you don't know. We didn't know actually that one of our DICOMs wasn't the same DICOM as the other DICOM, and we've had to do a bit of fix there. But that standards has allowed us to do it, and the will of the people has allowed us to do it. And absolutely the clinical need, the big benefit for me is, the eventual 3 benefits for me are: a patient never gets re-imaged because we can't find the prior image, or it will take too long. That's terrible for patients.
Mm-hmm.
And it happens a lot that we just re-image because actually that's the quickest way to get the image to a clinician. The second problem we have is people have to travel for their images. So it's easier to bring the patient to the trust that's treating them than to say to the trust that's near their home, can you just do this MRI for us? Can you just do this X-ray for us?
Yeah.
That's got to change.
Absolutely.
And that's got to change because we're looking to centralise more and more. Those specialist services are going into less and less units. So actually, we've got to be able to do all that locally. And then the third thing for me is reporting. So other people do it around the country. We're the 4th network in the country to now do cross-site reporting. So we can now have radiographers, we started radiographers who work in one trust reporting on the waiting list in another trust. And so that again is benefit to patients.
It certainly sounds like a more adaptable way of using the staff that you have to be able to sort of pool the work over an area. And as long as there's enough resource to deal with the total sum of the work, then you can deal with the ebb and flows within that. It's interesting that this area, digital diagnostics, is relatively ahead of the rest of the NHS in terms of interoperability. You're in a position where you can do some of the things that just absolutely aren't possible from EPR to EPR. And I just wondered if you had any thoughts about why that is. What's different about diagnostics that makes it sort of a solvable problem, whereas there is nobody suggesting we have federated networks of, between 17 different EPRs across a patch of trusts,
I started off early on talking about quietly successful.
Yeah.
And I think that's what I've seen, that actually off the back of the national programme for PACS, which had to happen the first time, didn't it? It was a national programme, you were put into groups. Actually, since then, people have quietly just evolved and said, okay, let's keep working together. All our contracts are aligned in terms of timing. Let's keep buying together. Let's improve every time we buy. And, people have been back to the market twice now, I think. And so I think we've seen people quietly working together, very, very clinically led. I think particularly radiologists are very IT savvy, and they're just quietly leading that piece of work. Pathology are playing catch up a bit, but have started to really get what they can do in terms of working together. And for them, digital pathology, so digital histopathology, is eventually going to be a game changer. And the reason it's eventually, because we're still missing a big part, and I don't know if you've ever been in a histopathology lab, you probably have, Marcus, at some point. It's the only place I work. I mean, people who work in there are phenomenal, but I think any patient or member of the public went in saying, it just looks so old-fashioned. There are people making tiny slithers of things by hand and putting them in glass by hand. And that's all going to go. So there are very, very big machines now that can automate that process. And some of the labs internationally, and we're starting to get them in England now, will start to automate those processes. So what you'll then have is a whole automated process. You're still going to end up with some glass that you still have to scan in and then look at the digital image. But hopefully somebody will close that last loop. That's my plan, that will happen. Because histopathology are under such pressure, every polyp, every organ now that, we're just looking for those tumours all of the time in histopathology, pressure is huge. We've got to do it differently. So it's a combination of automation and digitization that will make the difference, I think, in those areas.
It sounds very cool if that would be able to be less manual, because as you say, that is a hugely time-consuming process. Solidifying bits of tissue in wax and then slicing it up and then peeling them off and putting them onto slides and that sort of thing. It feels like that's the kind of thing that could be ripe for automation. And then we've got at least that stage is not going to be manual. And
again, I was just going to say it's interesting because NHS IT have seen this. There is, I think it's 30 million in a national pot. We're all currently bidding, you know, on that normal 2-week turnaround to get your bids in. So that's going on at the moment. But it's still back to, you know, actually we talked about money much earlier, didn't we? That none of this would have happened without NHS IT money for digital pathology. None of the automation would have happened without national money. So again, we're back to there isn't enough money locally. There aren't the right, either we don't have the right ideas locally or we don't have the right money locally. And there is still a huge amount of capital is controlled nationally. So frontline digitization, all controlled nationally. You know, digital diagnostics program controlled nationally.
Yeah.
So it's an interesting way to run a big organization.
Do you think that there are other models that would be better for managing those programs rather than nationally?
I think it becomes I've been doing bidding, I feel, for most of my entire career. I think I'm quite good at bidding, actually, and I've been pretty successful at it. But these are incredibly short notice. So, you know, in March, we were told there was probably going to be a fund. And in April, we were told to bid for the fund. And now we've bid and we've said, and now you need to write a business. Nobody can work at this pace well. And I think we failed to be strategic. You see it in all, either they move too slowly or they move too quickly, one or the other. But we somehow don't trust our organisations. If we're going to have these individual organisations, we don't trust them with the money. And we still keep a lot of that centrally. And I think part of what the NHS needs to think about in this latest round of reorganisation, of how much is actually delegated. You know, why isn't that money sitting with the local teams for local need rather than being controlled nationally?
Yeah. I've always found the bidding process slightly bizarre. And this happens in many walks of life, you know, grant awards and things for voluntary and charitable sector things. It feels like it's exactly the wrong way to go and find the areas of need and spend the money in those areas of need. Generally, the areas that are in most need have least ability to write a business plan and a bid for a load of funding within 2 weeks. So they get nothing. But the people who've absolutely got it nailed and who've succeeded in getting grant funding or bid for whatever funding there is, they become more successful. So you wouldn't do this if you were, you know, if you were trying to maintain a household and you had all the rooms in the house and you said, which are the rooms that need some attention? And I tell you what, each room needs to come up with a business case as to why it should get more painting and decorating or retiled or new electrics or something. Nobody would do that. You need to actually have a system where the person in charge of the house, in this case, knows what needs to be done by getting involved in all the areas and going and having a look and finding out what the need is. And I'm suggesting that there is another model for this, which is that, yes, have the money nationally managed, but don't expect people to bid from areas and ask for a specific amount of money. No. Actually, the central apportionment of that money needs to be determined by something a bit more intelligent than just they bid and we decided to give them some money or not. We actually need to know a lot more centrally about what is going on in every single region of the country, in every single trust. And that's obviously a very time-consuming and resource-intensive task. But is it any more time-intensive and resource-intensive than getting people to write bids over a 2-week period. That's just moving the work to the trusts and saying, we want you to tell us why you deserve some money. And as I say, I think you end up with a 2-tier system where the ones that are not very good at getting bids don't get anything or get less. The ones that are very good at it get more. And so gradually you get a diverification, or it's a disparity in the level of resource provision.
I mean, and you're right, Marcus. And when I say I'm quite good at writing bids, it sounds terribly arrogant, but it's partly because my team's time is extra. Actually, we have the time to go away and put those bids together, work with the teams, get it all written up in a nice format, find out how much things are going to cost. And you're right, I see that at every level. The teams that are really stretched don't even have time to think about writing a bid. And they're probably the people who need the stuff the most. And it's really hard to get that right. And it must be incredibly hard to sit at the centre, whichever centre this is, either the region or the national team, deciding the winners and losers on really small amounts of information that they get. So we've got to have a better system, I think. Theoretically, through the NHS 10-year plan, there will be more long-term strategic planning. So people are quite excited that we might have a 3-year capital settlement. I'm saying 3 years is nothing. It's nothing in the IT world. We need a 10-year capital settlement that says, over the next 10 years, this is the capital you can spend. Spend it when you need it, sensibly across this time period.
Yeah. Well, that would get you away from both short-term contracts and very long-term contracts, because they're both an anti-pattern, as it were. Very short-term contracts, you don't have the knowledge of the security of the future. You can't say we're definitely going to be able to renew at the end of this period, so you end up getting a less good deal. And then I think we've also had the opposite problem, where we get long-term contracts and get locked into a particular vendor and find ourselves almost unable to move.
Great.
I'm going to change the subject a little bit, just to we're coming to the end a little bit, but let's shift gear. We did nudge a little bit into AI before, but do you think that there's much to be done in digital diagnostics with AI? And are you doing anything at the moment in digital diagnostics with AI?
We are doing, so there is a national programme. So there's again, nationally, there's a national programme in imaging for AI, focused predominantly around chest x-ray. And that's what you had to bid for, was about 30 million invested. And those trusts that were successful are just getting to the point where they can start to do some evaluation. So we'll start to know a bit more, I think, about chest x-ray. I think it's been interesting, Marcus. I think I've completely changed my mind about AI. A year ago, if you asked me, it would all have been about image interpretation. It would all have been on the clever health end. And now I'm right at the other end. The AI we're going to get is around ordering. It is about, listening to conversations and interpreting the next thing to happen. It is about recording the next thing to happen. We're going to get that commercial AI come in, I think, much faster than we're going to get the health AI. And when I went to, last year, I went to one of the AI conferences. There must have been 500 startups there, Marcus. Most of them led by a young doctor, really enthusiastic, who'd written this piece of software for the interpretation of, liver CTs in a certain situation that would get used 100 times a year across the country. It was never going to scale. And I think we have to think about that differently, because it's commercial AI that will help us.
I would say that the thing that's wrong with that whole picture is the commercial bit. We're an NHS that is at a scale that we could be doing a lot of this ourselves. And whilst you're exactly right that the liver CT for certain specific circumstances that should be a plug-in That does
Yeah.
not need to be its own startup. It doesn't need the
No.
overhead of a business or an incentive like that. And no one's going to buy it for that one job. But
No.
if you had a national NHS picture archiving system, which is what you were describing, this idea of a national registry, the next stage of that is being able to add on clinical AI that can interpret some of those images. And then we can start building open source, shareable modules. And that's where it gets very exciting, because if one trust develops that module, all the trusts get that module for free. And what do they get in return? Well, they get all the modules that every other trust has developed for free as well. So it drives the total cost of ownership of that sort of idea, that platform, drops by 2 or 3 orders of magnitude, because you are not paying again and again and again for the same crappy bits of software from vendors. And we say we create a platform where plugins work, and each trust, we share the risk, as it were, or share the costs of developing those things. I mean, open source absolutely solves this. And it's sort of sometimes to see people banging their head against a problem that's been solved outside of healthcare, in that this kind of thing can be done at scale, at much bigger scale than the NHS even.
Yeah, of course.
But because of the reluctance to think in those terms, everything becomes, well, we want a thing, it's a procurement, and because it's a procurement, it's a commercial supplier. And that is what they call, in psychology terms, functional fixedness. They only know one way to use that tool, and so they use it that way.
Feels like a dream, Marcus, to be at that kind of place. Feels like somebody in NHS England would have to have that as their dream, that said, actually, what we need is a national AI platform. And I can't see anybody who's got that dream at the moment. It was difficult enough to have a conversation about platforms. So interestingly, in imaging, they jumped in and said, right, we need to go and buy some products to interpret chest x-rays. Fine, sure, they're all going to work. But they didn't say what we need is every network to have a platform in which to sit AI products. Could have spent the money really differently. And so actually there are lots of platforms out there now which have plugins. They're all a bit proprietary. You're not going to like it, Marcus, but they're proprietary. But at least they're platform based, because what we were very clear on in our network, we couldn't end up with 300 different contracts with small companies selling us AI. Never going to work. We want one contract with someone who is our NHS, our AI integrator, who's going to pick us the best AI available to do our work. So at least we had a strategy. We've got to pull that off. We are doing that at the moment, and we're starting to do our first piece of AI implementation on our platform. Normal stuff. Turns out it's not plug and play. That was my first report back, as always, from the team that are doing it. I think, well, never thought it was, but there you go. But we don't have that vision even to say what we need is platforms.
No, I mean, it's one of the things I find very disappointing and frustrating about the national leadership is that there isn't anybody with vision that works there. I'm sad to say. I don't look forward to a keynote from some senior clinical or technical leader at summer school, digital health summer school, or Digital Health Rewired, or HET, or any of the other shows, because I know it will be lots and lots of lorem ipsum about strategy and absolutely nothing about a vision that's technically feasible, deliverable. Let's build it, let's make something, and not waffle, but cold hard code. And they just don't seem to get it.
I think it might be this in the NHS 10-year plan. There's going to be something I don't know about. They've asked a lot of people's opinions, and let's hope it's in there. And I think it's also, for me, so federated data platform, we've touched on it a few times. Actually, you could argue that's visionary. Not in the way that it's been delivered, but the idea of having it is visionary.
Yeah,
but
I would agree with that.
but also the way it's done, people have got antibodies against it. And you think, well, how did we end up with antibodies against something that might be visionary? And so it's all about, there are many opinions in the NHS, aren't there? But we've got to find a better way of coalescing those and thinking about what are going to be the best things going forward. I find that we don't get asked our views very often. And that's one of the others of the problems, I think. I don't expect there's somebody at the centre who knows everything. That would be naive to think that. But how they ask people's views on what good looks like, it's a really easy question, isn't it? Yeah. Not sure how that happens.
Yeah, it's been difficult to escape the view in the past 5 years, at least, that a lot of the decisions that have been made centrally at England level and DH level have been influenced strongly by commercial interests, essentially lobbyists. And so if an order comes down the track that's actually political and it's come from a party, from cabinet, that filters through DH and then filters through NHS England, it's very difficult for them to do anything other than follow that order, even if they know that it will raise antibodies or it will cause problems and that it's not feasible or deliverable. And I think that's somehow how we end up in those slightly contradictory situations where no one can quite explain why we're doing something that is obviously wrong. But they're all quite happy to stick by it and say, yes, we're forging ahead with this thing that we know is obviously wrong, but we've decided that that was what must happen because reasons. It's a little bit depressing, but we've got to focus on the other things that we've talked about, which I think are very positive, which is the idea that the collaboration at network scale, the potential for a national registry of imaging, which would be excellent. I mean, that would enable, you can have a scan done if you fall and have a CT scan on holiday, and that scan's fine, but then later on you get some a further headache or something like that, go and have another scan back at home. They can compare the scans, without having to go and ask them to FedEx a CD-ROM or send something, as a very manual process, which I remember as an anaesthetist when in a former life, when I was a jobbing anaesthetist registrar. If I did a emergency transfer with a patient who was like a neurosurgical emergency or something, we would take the imaging with us on discs because they would need it at the destination hospital, and it was vital that we took that with us. And whilst we were doing what we needed to do, and that was right in the middle of the national project for IT. But it would have been nice to not need to do that those images and even, the medical notes could even follow across. But yeah, that's all that stuff is for the future, I guess. Thank you so much, Jane, for your time. I think it's been a really interesting discussion, and it's like everything, all of these discussions start to mesh together in that, threads of AI in digital diagnostics have linked up with other areas of AI going on. And it's kind of an exciting time to be in healthcare IT, I think. There's obviously a huge amount of turmoil at the moment because of the organizations, but in terms of the technology and what we can do clinically, I think it's really exciting. So thank you again, and please do come back and we can explore more topics or go even further into exciting things like DICOM. But for now, thank you, and goodbye, everyone.
Thank you. Bye.
Bye now.